Better street. All right. So today we're going to continue thinking about our factors that affect pulmonary ventilation. So we talked about our pressures that we're interested in, right? So we know that to figure out in and out, we're thinking about the pressure difference between the atmosphere and the pressure inside the alveoli, right? We started talking about how compliance can also affect how our lungs behave, because if our lungs aren't highly compliant, we're going to have to exert more physical force in order to create those pressures that we need inside our lungs. Okay. And we were also thinking about, at the very end, about lung compliance and surface tension. Okay, so when we were thinking about compliance, just remembering, so our compliance, right? We want our lungs to be more like veins. We want them highly compliant because we want to only have to use a little bit of force, create a little bit of pressure, and get lots of volume of air into the lung, right? We like that. Okay. But if we have low compliance, then we're going to have to exert a lot more pressure in order to get those lungs to expand appropriately, in order to get them to expand the same amount. So one of the things that can change the compliance of the lung is the surface tension inside the alveoli. So inside the alveoli, we've got moisture, right? So we've basically got some water. Water sticks to itself, creating surface tension. So we're breaking up that surface tension with our surfactant. This is the whole point of the alveolar type 2 cells. So sometimes this goes wrong, like in infants with infant respiratory distress syndrome, like one of the things that can be wrong is that they're not making enough surfactant, right? So they're having trouble breathing because they've got too much surface tension in the lung without this surfactant, affecting the compliance of the lung and therefore affecting their ability to effectively expand the lung. So we like surfactant. Surfactant decreases the surface tension inside the alveoli. And if we've got enough of it, it's making your breathing easier, making inspiration easier because it's increasing that lung compliance. So I want to think about that from like a picture view. Here's my pen. Okay. So we have a funny thing that's happening in the alveoli. So alveoli aren't actually all the same size. We've got these clusters of alveoli, some of which are smaller and some of which are bigger. They're connected with pores because we want air to move from one alveolus to the other. We want pressures to equalize. Okay, but this creates a funny thing when we think about surface tension, right? So we've got our water essentially pulling the alveoli in towards collapsing, right? The water is pulling towards other water molecules, okay? Right? So water pulling towards other molecules. And in a larger alveolus, right, that water is kind of like more spaced out here, right? In a smaller alveolus, right, we've got a fair amount of pull going on here. Those water molecules are closer to each other. And there happens to be a relationship between how much pressure you need to have in that alveolus, holding those walls open to resist the surface tension of the water in the lung. Now that pressure is dependent on the radius of the alveolus. So if we have some surface tension, some given surface tension, right? A smaller radius, right? is going to require a larger pressure to combat that surface tension than if we have a large radius, kind of like watering down that surface tension. We only need like a little bit less pressure. But if those are the actual pressures in the alveoli, then we've just created a pressure difference, right? We've created a low pressure. We only need a low pressure in the large alveolus, a high pressure in the small alveolus. So we're actually going to have air moving into the large alveolus and the small one collapsing, right? So that's why, in order to have equal pressure in all our alveoli, regardless of their sizes, we're going to want to distribute surfactant so that it breaks up that tension, that surface tension, in our small alveoli more than it does in the larger alveoli. But in general, we want to break up that surface tension as a whole. So the way we do that is inserting these like surfactant molecules in between our water molecules, just kind of blocking them from like glomming together. So that's why we care about that surfactant. So here we can see the picture of what's going on with the surfactant, right? So we have surfactant molecules. These are the surfactant molecules. They got like a little fatty acid tail there, right? And they're blocking those water molecules from creating that same surface tension. And when we have more surfactant here in that smaller radius alveolus, this brings down the surface tension in that alveolus so that we can have equal pressures from a smaller alveolus to a larger alveolus. The big picture of this is that the surfactant is breaking up that tension, stopping the alveoli from collapsing into each other, or just more generally collapsing from that surface tension of the moisture in the lungs. So we can breathe easier when we have surfactant in general, and also more surfactant in little alveoli means little alveoli don't collapse. So that's also helping us breathe easier, because we don't want just like one big alveolus in the center of your chest, because then you don't have enough surface area, right? We like our lungs to have lots and lots of surface area in those alveoli so that we can have good gas exchange with the blood. So compliance can affect how hard it is to breathe, right? Low compliance means it's harder to breathe because you need more pressure. You need to work harder to create enough pressure to expand the lungs enough to breathe in. The other thing that can affect how hard it is to breathe is resistance, okay? So that gets back to our flow rule, right? So for our flow, right, we know we need a pressure difference. In this case, we're thinking about the difference in pressure between the alveoli and the atmosphere. And something that can resist that flow is resistance, right? So a lot of resistance means less flow, right? And a lot of resistance can be caused by primarily a small little tube, like a small little radius, right? It's going to be harder to get flow through small little tubes. Okay. So what's happening in our airways is that they're getting smaller and smaller and smaller, right? So if we were looking at them just one by one, you might expect the resistance to flow to be high, but we're keeping overall resistance in the lung low because we have that splitting, right? So we could add up the radius of like all those little airways, and they'd come to a big enough number to keep the resistance overall low. The flow doesn't have to go just through one of those tiny vessels. Okay. So we like resistance to start out low, and we like breathing to be easy. So we don't want to have to create a big pressure difference. We don't want to have to work hard. And under normal conditions, we don't have to work hard. We're going to see like about 1 or 2 millimeters of mercury as our pressure change inside the alveoli as we're inspiring, right, and expiring. So we need a pretty low resistance for that to be adequate to create sufficient airflow. Okay. Now, since we only have a little bit of a pressure difference, right? So we're usually comparing like 0 to 1 or 0 to -1, depending on in or out, right? So if we've got like a 1 here, right? If we've got a low resistance, right, we can have some flow, right? If we start to jack up that resistance, we're going to have a problem, right? We're not going to get much airflow, right? So as we have increases in resistance, it's going to make it harder to breathe, right? You'd need to create a lot more pressure in this system, a bigger pressure difference between your alveoli and the environment, if that's how much resistance you have. So we don't want resistance to go up. Here's what would happen in the case that we do happen to change resistance, okay? So if we are looking at our normal resistance, that's this curve in the center, right? So usually under a normal resistance situation, our intraalveolar pressure dips down to a minimum of -1, and that sucks air in towards that low pressure environment in the alveoli. As air flows in, that alveolus gets filled up, so the pressure comes to equilibrium with the atmosphere between breaths. And then we start to let that chest collapse back in as we relax the diaphragm, relax the external intercostals, lung starts to recoil. That thoracic volume, that area is getting smaller. So the pressure builds up. Okay. Oops, following the wrong line there. Right. So then we hit a peak normally of about 1 until we go back down because air is escaping. Eventually we'll come back to equilibrium. Okay. Now, if we have increased resistance, right, in order to keep that breath volume the same, right, in order to breathe that same amount, right, because we're dividing our pressure difference by our resistance, right, if we have a higher resistance, we also need to have a higher pressure difference. So if you have an increase in resistance, now instead of getting those alveoli just to -1, to breathe in the same amount, you're going to have to take them all the way down to a pressure of -2, possibly, right? You'll still go through that normal cycle, come back to equilibrium, and then start collapsing down. And now to breathe out, you're going to have to go up to a higher pressure difference as well, right? So you're trying to overcome that resistance with a higher pressure difference. But that means you're literally working harder to force this air moving around to create these pressure differences to keep that same volume of air. Okay, so that's why we don't like high resistance. In terms of what can affect that airway resistance, going to be similar things to what we spoke about when we spoke about blood vessels. So now instead of thinking about vasoconstriction and vasodilation, we're going to be thinking about bronchoconstriction and bronchodilation. Those are going to really just mean the same thing, right? Bronchoconstriction is going to be getting smaller. Bronchodilation is going to be getting bigger. But our different hormones and parts of the nervous system may affect the respiratory system slightly differently than the cardiovascular system. So from a physical perspective, what we're going to be thinking about are some passive forces. So in terms of passive forces, they're going to be more like of our normal forces. We already know that we have some changes in pulmonary pressure during the respiratory cycle. So that transpulmonary pressure is the distending pressure across the lungs. Get it by comparing, taking the difference between the pressure inside the alveoli and the pressure of that interpleural fluid, right? Interpleural fluid, right? So that's what's keeping those lungs stuck to the inside of the chest wall, following along the chest wall. So if we change that transpulmonary pressure, if we change any of those things, we might change our breathing cycle a little bit. We also have a similar thing going on when we think about something called tractive forces. So this is a similar concept, when you're breathing. Like you're breathing in, inspiration, right? Your chest is expanding. The physical tissues are also going to pull a little on the long way on the airways. So not when we think about the transpulmonary pressure, specifically what that's talking about is how that pressure of the intrapleural fluid is kind of pulling on alveoli. Tractive forces, think like a little more hands-on. We're thinking literally about the tissue side of that equation. So both of these things create expanded airways. We open up airways. And so we're going to be lowering resistance if we have a more open airway, right? Wider means lower resistance. We also have smooth muscle in the walls of our airways. So if we take a look, right, we're going to expect in cross-section to see literally a layer of muscle in our airway. Okay. So much of what we're going to be thinking about when we think about changes in resistance, it's going to be the state of that smooth muscle, right? So it's going to be just like when we talked about arterioles and how they can change their resistance by clamping down, vasoconstricting that smooth muscle, or expanding, vasodilating that smooth muscle. Same thing's going to happen in our airways. If that smooth muscle clamps down, we get a small radius, higher resistance. If that smooth muscle relaxes, we're going to have bronchodilation, bigger airway, less resistance. A new factor could be mucus. So if we think about mucus, right, we're thinking about like basically a kind of globby layer lining the inside of the airway. So effectively, if you produce more mucus, you're narrowing that pathway for air more and more, right? So now our airway, right, with extra thick mucus is smaller than it was before. So if we have too much mucus, essentially what we're doing is creating a small radius. So that's also going to increase our resistance if we've got a lot of mucus there. Okay. So we're going to focus mostly on what's going on with the smooth muscle. So here we have our basic definitions of terms, right? So broncho is always referring to our lungs, specifically like our bronchioles, right? So that was one of the levels of our airways, right? So we're going to associate it with that, right? So bronchiolar smooth muscle. Okay, so constriction, getting smaller. When we have that muscle contracting, our radius is going to get smaller and smaller. So that's our bronchoconstriction. Okay. Bronchoconstriction means it's harder to breathe because you got a little tiny airway. Our bronchodilation is going to be dilation, so expansion, widening of those airways. So as that smooth muscle relaxes, we open up our airway, right? Now we got a big fat tube. It's easier to breathe through that wider bronchiole. So air can move through that greater diameter more easily. So the contractile state, so how contracted that smooth muscle is, it's going to matter for determining how much resistance is in that airway because it's changing its radius. And unsurprisingly, we're going to have control of that smooth muscle, both at like the local intrinsic level, as well as some of it coming from our extrinsic level. So things like nerves and hormones. So we'll take a look at that. All right. So in terms of our extrinsic control of our bronchiolar radius, we are mostly thinking about our autonomic nervous system, right? So the autonomic nervous system is our contrast to the somatic part of the nervous system. These are all branches going out towards muscle, specifically autonomics, one of their effector organs, that smooth muscle. We break ourselves into two branches, our sympathetic, our fight or flight part of the autonomic nervous system, and our parasympathetic, that rest or digest part. Okay. So we're thinking about like a fight or flight situation, right? You're running away from something, you're working really hard to fight someone off, right? We know that we're going to want that heart pounding, right? So we know sympathetics raise heart rate, increases increases our cardiac output in multiple ways, increases stroke volume, right? We saw that we're going to use that sympathetic nervous system to send blood specifically to the heart and skeletal muscle, but we're going to constrict everywhere else in order to keep our blood pressure up so we don't faint. Now we're thinking about our airways in the same situation. If we're running away or we're in the middle of a fight, we want to have enough air. We want to have enough oxygen. Our muscles are working hard. So this means, conveniently, the sympathetic branch of the nervous system is going to bronchodilate, right? So under these conditions, we're going to want more air. So we're going to want those airways to expand. That's bronchodilation, right? And we do that by relaxing smooth muscle. So we get more air, in part because of that reduced resistance as this bronchodilation is happening in response to the sympathetic part of the nervous system. Now, a new thing, we haven't talked about our parasympathetics much in a while, right? So our parasympathetics were less important when we were thinking about our blood vessels, but they are going to affect our bronchioles. Okay? So for our parasympathetic branch of the nervous system, that rest or digest part, this is going to cause constriction, contraction, right? So when you're resting, those bronchioles are going to constrict a little bit, right? Our parasympathetics can clamp those airways back down a little. So we do have this kind of back and forth option for our airways. Other extrinsic controls of bronchiolar radius, other than our familiar autonomic nervous system, really we're thinking hormones, really we're thinking epinephrine. And we kind of always think about epinephrine in association with the sympathetic nervous system. So that hormone, that epinephrine coming from your adrenal medulla is going to be relaxing your smooth muscle, just like our sympathetic nervous system as a whole was. So we're causing that same effect, that bronchodilation. This is still that kind of like almost a stress response a little bit, or helping us adapt to stressful situations. So bronchodilating, opening up those airways. In terms of our intrinsic control for our bronchiolar radius, we've got one more thing that can help us dilate. All right. So locally, we've got our friend carbon dioxide here. Okay, so we saw that carbon dioxide levels and oxygen levels near the arterioles had an effect on blood flow. The overall goal of making sure that we're getting sufficient blood flow to tissue. Now we have an analogous process going on in the lungs, right? So what happens in the lungs is that we want to make sure, especially, that we're breathing out all of the carbon dioxide that we produce. We really don't want carbon dioxide building up in our system. So actually, even though we focus on breathing in a lot, breathing out is quite important to your body's regulatory processes. So when we start to see carbon dioxide build up specifically, this is going to have the effect of dilating those bronchioles so that hopefully you can breathe out more air, right? You want to breathe out that carbon dioxide. This is going to help things even like the pH balance of your blood, right? So it's important. Okay, so that would be an intrinsic control of bronchial radius that has the same effect as the epinephrine from our hormonal level, that sympathetic nervous system from our autonomics. We also have an intrinsic reaction that helps us bronchoconstrict. Okay, so bronchoconstriction, we saw a little bit of it just now with the parasympathetic branch of the autonomic nervous system. The other way you might see bronchoconstriction is when we produce histamine. So histamine among other things, is released during asthma and allergies. That's usually when we think about it, when we're thinking about the respiratory system, right? If you ever think about like your throat potentially closing over during an allergic reaction, you're thinking about histamine and its bronchoconstriction effect, right? So it's bronchoconstricting, clamping down the airway potentially, but it's also increasing that mucus secretion, right? So it's kind of affecting that airway in two ways, right? So we have two reasons now that our airway is narrowing. First, we've got some constriction from the histamine in the first place. And the second is that we're creating that mucus layer, further narrowing the airway. All right. So tapping in, which of these were creating relaxation of the smooth muscle? So we've got some extrinsic factors, some intrinsic factors. Some of these describe bronchodilation. Take another couple seconds here. All right, great. Okay, so yeah, what we were just looking at when we're thinking about relaxing bronchial or smooth muscle, we're thinking about bronchodilation. We've got that epinephrine. We've got carbon dioxide. We might also add on sympathetic stimulation, but definitely not the parasympathetics. And extrinsic means we're coming from somewhere else, right? The carbon dioxide is going to be local. It's going to be right within the lungs, versus the epinephrine is extrinsic because it's coming from our adrenal glands. So when we think about airway resistance, often when we think about these changes, we're thinking about pathological states or disease states that are affecting the resistance. So one of these is asthma. So what's happening with asthma is we're having spastic contractions, so like intermittent contractions of the airway. Okay? And to begin with, actually, an asthmatic airway is a little different looking in its relaxed state. So here we see a normal airway with a big wide pathway, right? In our asthmatic airway, we can see we've got airflow, but we've already got some kind of like inflamed and thickened airway tissue surrounding it, right? So we can see that even in that relaxed state, we got a little extra irritated smooth muscle. Okay. Now the problem during an attack is that that smooth muscle decides to spasm, decides to constrict down, and it's probably meant to be a helpful response, right? So we don't usually think with an airway that we want higher resistance, but if you were in a dangerous environment and suddenly there's like smoke in the air, right? You might not want to breathe in various pathogens, things in the air surrounding you, right? So under those circumstances, you might want to like limit a little bit breathing in pathogens, right? So in an asthmatic airway, we're kind of creating this response when we don't actually want to be, right? So we can see that we have tightening of that smooth muscle, right? And we're decreasing that radius even more, jacking up that resistance. Super small airway. That's why it gets hard to breathe. And you have to work harder to breathe. When we talk about changes to resistance causing trouble in the respiratory system, we often refer to these as obstructive pulmonary diseases, right? Because we're physically like obstructing airways. So COPD, the full term that stands for is chronic obstructive pulmonary diseases. It's a general category including like emphysema and chronic bronchitis. So these are both things that can affect the resistance of the airways, causing difficulty breathing overall. Now, if we wanted to talk about how someone's lung is functioning, right, how they're doing, we really want to talk about how much air are they getting and how much good, fresh, oxygen-filled air is getting into the lung. So in order to do that, we might talk about specific volumes of air, as well as capacities for holding air. We might talk about specific pulmonary function tests. So they might have you like breathe into tubes and test certain things during that process. And then as we start to think about the specific gases that you want to get into your bloodstream, you might start to think about what we refer to as alveolar ventilation. So we're going to start by thinking about these lung volumes and lung capacities. So a way traditionally they used to measure these was with this complicated process where we had a bell submerged upside down in water that you would breathe in and out of, attaching that to a transducer that gives a little pen, jiggles depending on how much air you've got moving around. As that air either fills, floats a bit more, or sinks when there's less air in it. So this is the process of spirometry. So what we're looking at here is a spirograph and a spirometer. Nowadays, I don't think we really need this bell and water system, but we do make similar kind of measurements. All right, so we're going to start by thinking about how we break up our total lung capacity. So for our total lung capacity, we're going to be adding together many different volumes of air. Okay. So for our total lung capacity, we're going to start by thinking about our tidal breaths. So the tidal volume is just our normal in and out here. So a single unforced breath is moving about 500 milliliters of air. Okay. So that's what we see in the center here is our tidal volume. But you're not moving most of the air in your lungs when you're just relaxed breathing, right? We're just moving enough air to appropriately balance our gases, but to conserve our energy and not work too hard, right? So this is why, right, if you're meditating or doing yoga or something, you can breathe shallowly, breathe your normal amount, and then you might be told to breathe in a second deeper breath, right? So you can try it, right? Breathe normally. And then at the top of your breath, try and take in more air than you usually would. Right? So what you just breathe in on top of that tidal breath, right? That is our inspiratory reserve volume. Okay. So actually, compared to the resting amount of air that you're moving, usually That's quite a lot. So there are 3,000 milliliters of air, roughly, that you could be moving, but aren't under normal conditions. Okay. So that goes into our total lung capacity as well, right? Because we're thinking about the total ability of the lung to hold air. So that's our inspiratory reserve volume. We can do the opposite too, right? Breathe normally and then breathe out after the bottom of a normal breath. Right? An additional forced breath out. Right? So if we're breathing normal, here we can see that going back, just moving that tidal volume. And then a second further breath out. That's your expiratory reserve volume. Okay. So that's also substantial, not as big as your usual inspiratory reserve volume, but there's some amount of air that you're leaving in your lungs that you could move out, but you usually don't. You usually just kind of leave it there. Okay. So from our maximum inspiration to the top of a normal breath, we had the inspiratory reserve volume. Our normal breath is about 500 milliliters, covering that tidal volume. From the bottom of the tidal volume, if we breathe all the way out, the most we can, work as hard as we can, we're adding on our expiratory reserve volume. But now we actually still have a bit of air in the lungs. So we still have a residual volume left in our lungs, right? And we talked about that. And we mentioned it when we were talking about like the conductive part of the respiratory system, right? So the airways that are not respiratory, right? In your lung, you also still have a bit that you just can't move out, right? And this is because you don't want that lung to collapse. So you want to leave like a little bit of air in those alveoli because otherwise their walls are going to smush together. They're going to be hard to peel apart, right? They're going to create a bunch of surface tension, right? So you have a little bit of residual volume that you can't move in the lung itself as well. Okay. So that residual volume is about 1,200 milliliters. It's left even after the end of your maximum respiration. And if you wanted to measure it, you could use helium to kind of dilute the air and do some calculations on that to figure out how much of it was left in the lung, even as you're moving the air. Okay, so those give us the total capacity of the lung, right? So that's like all the air. And we didn't have any of these pieces overlapping, I should note, because when we talk about our next couple measurements, we're going to be thinking about some of these overlapping. So non-overlapping, we had our tidal volume, right? We had our inspiratory reserve volume, our expiratory reserve volume, and our residual volume. Okay, so non-overlapping, we can just add them together to get our total lung capacity in total. So those are the volumes for lung volumes. So that takes us to the capacity part of this concept. Right, so the capacities are not going to be exclusive, right? So we're going to add together things to get different lung capacities that we might want to talk about. Okay. So for our first one, our inspiratory capacity, right? Our inspiratory capacity is just referring to how capable are you of breathing in, right? So we want to think about all the air you can suck in. We don't care if it's a little breath, big breath, right? So to find that inspiratory capacity, right, from our volumes, we'd be taking that tidal volume, right? So you breathed in the normal amount. And then we're going to add on that inspiratory reserve volume, right? So that's that deeper breath. So these two things together give you your inspiratory capacity. So all the air you can breathe in total. Our vital capacity is going to be slightly different. So what we're going to do for our vital capacity, right, is we're going to take a maximum inspiration, right? So all the way, all the air in we can get, top of our lungs, right? And then we are going to breathe out as hard as we can, as much as we can, until we get to that minimum, right? So what the vital capacity is essentially like, what is the total amount of air you can move, right? So not just in, not just out, but all of it, right? So in terms of calculating that, we're going to add up the tidal volume, right, that was in the middle there. Since we started at the top of a deep breath, we're also going to need that inspiratory reserve volume, okay? So those two things together were our inspiratory capacity, okay? But we have to add in that deep breath out, right? So our expiratory reserve volume. And now we have that vital capacity. So basically the vital capacity is everything but that residual volume. And then the total lung capacity is the whole thing, right? TLC, total lung capacity is all our volumes stacked together. So we're thinking about volumes as like sections of your breathing, sections of the air. We're thinking about capacities as like thinking full breaths in, or just all the air you can move, or all the air in the lung. So when we're thinking about a capacity, it may be overlapping. And the best way to do it is to just think about adding together those non-overlapping volumes to get the capacity, because then you don't have to worry about comparing capacity and capacity. So we do have one more capacity that we want to think about here, right? So we have our definition of total lung capacity, which we looked at, but we also have our functional residual capacity, okay? So for our functional residual capacity, we're thinking about a resting easy breath, right? And then we are thinking about all the volume remaining in the lung at that point. So not just all the volume you could move, but like all the air that's in the lung, right? So we're thinking about everything in the airway. So we have to stack together that residual volume that's going to be in the lung no matter what. And we have to add on that expiratory reserve volume that usually you wouldn't be moving, but you could force out if you wanted to. So that's our functional residual capacity. Right? So functionally in everyday function, that's how much extra volume there is in your lung, extra air, residual capacity. Questions about how we compare these volumes and capacities. This is probably a good like flashcard or Quizlet type of structure, because we just really want to know what they are. So if you have to measure them or talk about them with a patient, right, you know what you're talking about for each of these. So which one of these would count as our vital capacity? Right, let's take another couple seconds. Okay, cool. Yeah, so our vital capacity, we're talking about the vital capacity, like vital to your life. We're thinking about all the air you could move. So we're thinking about the tidal volume, those are your easy breaths. We're thinking about all the extra at the top of a breath, which is your inspiratory reserve volume. We're thinking about all the air at the bottom of your breath, which is your expiratory reserve volume. Perfect. So we will dive into these a bit more next time, but we're going to introduce them just right now. So we talked about obstructive pulmonary diseases. We mentioned them as associated with resistance, right? So if we're looking at an obstructive pulmonary disease, the cause of that is going to be the resistance, right? It's making it harder to breathe because you're really not able to move that air as quickly as you should, okay? And so functionally, what we're going to end up seeing is that the residual volume, so like the amount that's left in your lungs that you kind of can't move, is going to be increasing because that resistance is increasing. It's physically harder to move stuff. So we might end up with lungs that get overinflated. Another type of disease we'll see are restrictive pulmonary diseases. Okay, and I'm sorry that restrictive looks so much like the word resistance. It's not the same word. Restrictive pulmonary diseases have to do with compliance. Okay, so both of these types of diseases make it harder to breathe. Obstructive ones, because we have changes to resistance. Restrictive pulmonary diseases, because we have difficulties with compliance. Lower compliance means it's harder to breathe. Okay, so we'll get into exactly how these are associated with these specific lung capacities next time, and examples of how we might test for these two types of diseases.